My name is Alexis Wing, and for the second part of our symposium today, we are going to have two sets of poster presentations. The first presentation is titled Motherhood Together, A Journey in Love, using prenatal education to promote knowledge of women suffering from housing insecurity, and this will be co-presented by Shannon Kalkwarf and Elizabeth Riley. Shannon is a clinical instructor with the College of Nursing at the University of Arkansas for Medical Sciences, and teaches students in the Family Nurse Practitioner track. Shannon served as a main curriculum developer for the Motherhood Together, or MT curriculum, and co-taught and co-facilitated several of the weekly MT sessions. Elizabeth is an assistant clinical instructor with the College of Nursing at UAMS and teaches students in the traditional BSN program. Elizabeth has served as a main developer of presentations and manuscripts to further discuss the curriculum for the Motherhood Together program. The second presentation we have is titled Eliminating COVID-19 Related Birth Disparities Through Telehealth, and this will be presented by Jennie Joseph. Jennie Joseph is a well-respected health advocate for women and newborn babies. A British-trained midwife, Jennie has become one of the world's most respected midwives and authorities on women's health, healthy pregnancies, healthy deliveries, and healthy babies. Jennie is the founder and executive director of Commonsense Childbirth, Inc., but more importantly, she is the creator of the JJ Way, a common sense approach designed for women and children. She moved to the United States in 1989 and began a journey that has culminated in the formation of an innovative maternal child healthcare system, markedly improving birth outcomes for thousands of women and children. And without further ado, I will go ahead and pass it to our first presenters, Shannon and Elizabeth.
Hello, thank you for viewing our poster. My name is Shannon Kalkwarf, and my co-presenter is Elizabeth Riley. We also want to acknowledge the other authors listed. Our poster is titled Motherhood Together, A Journey in Love, using prenatal education to promote knowledge of women suffering from housing insecurity. The learning objectives for this poster relate to being able to identify how housing insecurity relate to the social determinants of health, illustration of Maslow's hierarchy of needs as a framework for vulnerable populations, and the importance of using the March of Dimes curriculum for prenatal education for women suffering from housing insecurity.
In 2018, faculty in the nursing and the public health colleges at UAMS became aware that on average about 30 to 40 babies were being discharged from the hospital in the central Arkansas area to families who were facing housing insecurity or homelessness. This was a stark call, and faculty wanted to find a way to help these families. While housing insecurity or homelessness itself is not an actual social determinant of health, it does relate to the social determinants of health, specifically regarding physical, environment, and economic stability. Several research studies show that the social determinants of health can play a powerful role in both maternal and neonatal outcomes. Therefore, faculty wanted to create a program to enhance prenatal education and Maslow's hierarchy of needs for our participants in an effort to improve maternal and neonatal outcomes of our population.
The purpose of Motherhood Together is to promote positive maternal and neonatal outcomes for pregnant women experiencing housing insecurity. It creates a sense of community through supportive group interactions for maternal self-care empowerment. We group participants by similarity of their life contextual circumstances and lived experiences, and not merely by gestational age. In each cohort, we've had 3 so far, the mothers have developed a bond with each other, provided advice and support. As we discuss the topic for each week, we talk about real life situations that impact them on a day-to-day basis, such as difficulties with housing, getting to prenatal appointments, how to get bus passes, or get to the health department for WIC enrollment, or also how to deal with partner or family stressors. Motherhood Together is based on the Maslow's framework to ensure the basic needs of participants related to pregnancy and housing insecurity are met. We focus on physiological needs. We provide meals and to-go meals for moms each week. We have a food pantry at the clinic where we hold the classes and pass out canned goods if needed. We pick up and drop off our participants, and we hold a safety baby shower where they can discuss safety for their infant. They all receive a portable crib and infant car seat. Domestic violence is a topic that we discuss. We had one mom who had a domestic violence occurrence and needed help with getting to her mom's house in Texas, and we're in Arkansas. We stayed with her throughout the morning to coordinate getting her things with the police escort because she was scared to go home, and a bus pass to take her to her mother. Love and belonging are a big part of our program. We build a bond with our mothers. We want them to know and understand that they have support through our Motherhood Together program, and they are not alone. We emphasize the value of bonding and love with their baby. We have a chart listed here on what topics we cover each week, and this curriculum is adapted from the March of Dimes. So for week 1, it's all about getting to know our moms and them getting to know us. We just have a brief pregnancy overview, and we focus on nutrition that first week. On the second week, we talk about things to avoid in pregnancy, and a big part of that week is talking about stressors in their everyday lives. Week 3 is about prenatal care. Week 4, we talk about the big day, delivery day, and then a postpartum overview. This week, they could bring their partner with them if they choose to do so. Week 5 is a continuation of the big day where we empower these women to create a birth plan specific for their wants and needs. We again go over the labor and delivery day and then the immediate postpartum period. Week 6, we talk about postpartum depression and the signs and symptoms of depression, postpartum changes, warning signs they need to look for when it comes to things like preeclampsia postpartum, and then birth control options if they want to learn about contraceptives. Week 7 is all about feeding their baby, breastfeeding, bottle feeding, formula, milk storage. And week 8 is when we hold the safety baby shower we mentioned earlier. And then a pediatric certified nurse comes and teaches the moms infant CPR. Week 9 is about bonding with their baby, couplet care, infant care, and we talk about daycare as well. And then our last week, we have a big graduation day for our moms.
Motherhood Together has been implemented with 3 separate cohorts for a total of 15 participants since its inception. We feel that our certified nurse midwife facilitated sessions in conjunction with advanced practice registered nurse support with smaller groups of women has really provided additional education, support, and belonging that these women may have otherwise not gotten. While prenatal education was the focus of our program, the sessions do need to be targeted towards the specific population and their needs, which will be much different from pregnant women who are not facing housing insecurity. We're happy to report that all of our participants have had positive maternal and neonatal outcomes, were connected to appropriate resources, some were able to obtain employment and stable housing, and one participant that we know of has begun earning a college degree. We recognize that a 10-week program will not fix all of our participants' problems, but our goal was to provide additional individualized support to help participants begin to live healthier lives. In conclusion, we'd like to acknowledge the grant funders who made this program possible, which includes the UAMS Interprofessional Education Department and the National Wonders Partnership Council. We're happy to take any questions you may have.
Thank you so much, Elizabeth and Shannon. That was really great to hear. We have one question so far from Tracy, and the question is this program voluntary? Is there a component of housing search support with this?
Yes, thank you for your question. So participation in our group is completely voluntary. We have flyers put up at the obstetric clinic at the academic medical center we're associated with, so they can look at the flyers, and if they want to participate, we have a phone that they can call, and we can set up everything that they need, transportation, and just talk about the program to see if they're interested. We've also partnered with Our House, which is a nonprofit organization that has housing for families who are in need of that, social workers, and a lot of they have a lot of resources to help women in these situations. So we've partnered with them, and if they are, in between houses or do not have a permanent place to stay, and they don't already have a social worker working with them, then we contact Our House and get them plugged in with the support that they need for that.
Okay, thank you for answering that question. And we also just have a comment that this is an amazing program, and I would absolutely agree with that. And I don't see any more questions coming in through the Q&A or the chat. So thank you so much again, Shannon and Elizabeth, for that wonderful presentation. And I think I'm going to go ahead and pass it over to Jennie to share now. So whenever you're ready, Jennie.
Thank you. And okay. So thank you very much for the opportunity. Thank you for sharing, Dr. Washington and Shannon and Elizabeth. My name is Jennie Joseph, and along with my colleagues, Nwafor, Kendra Ippel, and Thometta Cozart, we have a poster here which is really helpful in just kind of pointing out how we decided that we would have to, it wasn't really optional, but we had to find a way to manage what was a very busy clinic when COVID-19 hit. We have been providing a midwifery outreach clinic for over 10 years now, where we have made it our purpose to reach women who are marginalized, women who are uninsured, women who are undocumented, women of color, low-income women, women who are not getting prenatal care access, not through any fault of their own. Most of it is due to social determinants of health, due to our systems which are full of bureaucratic hurdles and obstacles and ways to keep women from getting the care that they need. And so we have set our clinics up, and we've called them easy access clinics for that reason. We knew that there was a need to address the potentially poor outcomes that women in this group face by not having access to quality or safety, respectful care, and not having an understanding of how to circumvent a broken system. So everyone's familiar with these problems. We know that our outcomes are outrageous and a disgrace, frankly, in terms of the rest of the world's maternal and infant outcomes. We are 48th in the world for maternal mortality in the United States, 57th, I believe, for infant mortality. Things that just don't make any sense in the most resourced and most developed country in the entire world. What is very stark is the disparity between Black mothers and white, or Native American mothers and white. We are looking at 3 to 4 times the number of women being lost through perinatal mortality and morbidity compared to white women. And as far as infants, at least 2, sometimes 3 to 4 times as many infants are being lost. So just put it simply, our mothers are dying, our Black babies are dying or suffering, because if you're almost dead, you're not quite a statistic. Near miss is a big problem for the United States, and there are some 60,000 or more near misses that are accounted for every year. And I think it could be way higher than that, because as we all know, especially we women, we don't share. We don't have an opportunity to share. In fact, nobody's even asking. You are basically on your own. You have your pregnancy, your birth, and you're out the door, and nobody's particularly bothered about you again unless you're pregnant again. So we were really concerned about that. And then when COVID-19 hit, we realized that the impact of that was that the supports, the few that there were being pulled right out from under people, and particularly, again, marginalized people. So you may have heard about doulas being stopped at the hospital door and not let in to support their families during the labor experience. You may have heard about physicians and obstetricians unable to manage because of social distancing and reverting to telehealth. We at first thought that telehealth would be a problem too. It turned out not to be the case. So my method of approaching the issue of perinatal health in America is based on my British training as a midwife, but also based on 4 tenets: access, connections, knowledge, and empowerment. And we found that very early on that if we had unimpeded, unrestricted access, that we would then be able to provide the triage that is missing in most cases. So it could be medical triage was needed, whether a person really could stay with a midwife practice or needed to be with a perinatologist team, or whether it was access to, I can't figure out how to get this Medicaid application through, and until you can get it in, you can't actually get Medicaid. Access to financial recognition of where can you go for resources, or how can we help you, even homelessness, as was just mentioned. So access was the key. And once we made that clear and opened up the access, women were feeling more relaxed and able to connect with us, to trust us. In fact, many were incredulous that they could have access to support in this level. Once the support is in place and they feel safe, they feel respected, they will learn and understand anything you put in front. In fact, they'll ask for that information and in turn become empowered. When we had to pivot to telehealth, we were scared that we would lose that opportunity to provide care in this way. Because for the last 10 years or so, we've been able to produce statistics that have shown that we have very few premature babies, very few low birth weight babies. Our mothers go to term, very little incidence of preeclampsia and gestational diabetes, and majority of the women are breastfeeding, whether they are delivering in the hospital environment or delivering in the birth center environment. So we were concerned when we went to telehealth that we might lose that. And quite the opposite has happened. So our telehealth is via telephone or via video call, and it's the mother's choice which one she wants. And not everybody wants to be on the video, interestingly enough. But what we found was that we were still able to provide a connection very quickly and have women feel comfortable and feel safe. And they were still willing to disclose any of their concerns. They felt that they were being listened to. They felt they had more time. And then along the way, as we got better at it, we started getting donations to provide Dopplers for home visits, urine test strips for home visits, blood pressure cuffs for home visits. And during the course of that telehealth exchange, whether it's by phone or video, the mothers were able to check the baby's heartbeat with the midwife on the call. They were able to go pee on the stick and read the numbers and the letters together, that we were able to look at the colors and make sure the urine was clear. We were able to get a blood pressure reading. And so we began to provide these telehealth kits to support the telehealth calls and video exchanges. During that time frame, from March until August, we had 88 mothers deliver out of the practice. One baby was born at 34 weeks and survived. She was very robust, 4 pounds, did great from inception. She had no trouble and is home and doing well. And we had one low birth weight baby at 5 pounds 1 ounce. These are women demographically who are going to be the women that constitute the statistics that we are so concerned about. These are women who are from low income neighborhoods, who have food insecurity, housing insecurity, have no real support from any other source other than during the time when they have prenatal care, and work with our midwives, our doulas, our childbirth educators, and our community health workers. But we were able to do the same level of care, the same intense one-on-one support, non-judgmental care, respectful care, maintain the dignity that is imperative for physiological good health. And so we are very proud of what's happened, and considering that it was obviously a forced pivot, it wasn't something we were looking to do, but we are now clear that virtual maternity care can be delivered safely, with quality, and that what we need to do now is train the workforce to be able to embrace that as an opportunity to create even greater access than we had heretofore. So I believe it's important to recognize that just being really creative around little or no resources, and that's something I think that we've done as midwives forever, because inside of this current system, what I call the medical industrial complex, there is no room or acknowledgement of midwifery as protective for mothers and babies' health. So we plan to move forward now. We are doing more studies. We are doing a survey. We're looking at the response from the mothers and families on how they feel the telehealth is going. But we are absolutely clear that this has opened up the door for more providers, maybe across state lines, more collaborations, and more ability to reach women where they are, to provide the access, connections, and knowledge and empowerment that they need, but we as providers also need. So I'm more than happy to take questions, and thank you very much for having me today.
Thank you so much, Jennie, for sharing that. That was really great to hear. And there are a lot of questions coming in the chat right now. So go ahead and pick the first one. The first question that I am seeing is, do you think telehealth will continue to be a major factor post-COVID? And how does that impact the patient-doctor relationship, which I think you might have alluded to a little bit when you were speaking?
Yes, I think because we are working from a midwife model of care, we may have a different approach for that provider-patient relationship already. I mean, basically, we provide patient-centered care, and that's always been the case. My little secret thought is that hopefully we can encourage more physicians to embrace the idea of patient-centered care, because telehealth allows the physician to actually practice in a different way. So for example, you have to look them in the eye if you're on the video. You just have to, you just have to do that. You also, if you're on the phone, you have to work a little harder to engage the communication, because if you're getting one-syllable answers, for example, you can tell that there's not a warm connection yet. And so you have to do some extra work to get that to happen. So it does come down to the will of the provider, whether they're open to the idea of doing this extra work, because historically, it has made better sense for physicians to stay distant, to maybe think that might be protective. I don't know that that's really the case, but there's not a push in terms of medical practice to get more engaged with patients. It's rather the opposite. It's let's hurry up and move the clinic, let's get them in and out, let the nurse do all the touchy-feely and the provider stand back. Telehealth, I think, will force us to have to figure out ways to engage in a different modality, but actually I think it's a win-win, because my staff are loving it. We feel better, we feel more empowered, and we're getting more done. We're seeing more patients with this modality than we could if they were on site in the building.
Thank you, Jennie. It sounds like there's been a lot of success with telehealth, which is awesome to hear. And the follow-up question to that is, what platform do you all use for telehealth? Obviously, we're on Zoom right now, so I'm not sure if you're using Zoom or another one.
We haven't used Zoom or FaceTime. We actually use a medical electronic health record, which has incorporated a telehealth platform into it. And there was one before that we used, which was also HIPAA compliant. And although the state and the federal government said, because of COVID, you can waive the HIPAA compliance with some of these modalities, we felt that was actually not the best approach. And we made an effort to make sure we stayed inside of those guidelines. Patient safety and patient privacy is extremely important to us, and we wanted our patients to know that as well.
Awesome. Thank you, Jennie, for answering that question. I think there might be time for one last question. And I'm seeing in the Q&A here, someone who works in a home visiting program that is now providing telehealth, that is pivoted to providing that, and is wondering what you think are the key factors in gaining a family's trust if you have not met them beforehand.
Keeping it light. We joke and laugh a lot, and I try sometimes to just go straight to recognizing what it's like being pregnant, whoever you are, whatever your demographic. So, girl, how's it going? How's your back? Is your back aching? Oh my goodness, yes. Oh, is that baby kicking you? Are you getting any sleep? Anything that she can immediately relate to because she's pregnant. She's gonna go right back. Yes, that's the worst thing, and off we go. And that's all it takes, a little icebreaker, and we're rolling.
Awesome. Thank you so much, Jennie. It was really great to hear your presentation, all the great work that you are doing. And I think I'm going to go ahead and pass it back to Nikisha now to take us into the next section of the symposium.